Usually when we think about physical pain, we look for an obvious, immediate injury.
Right.
Like you cut your finger, you see the cut, you feel the sting. It's just simple cause and effect.
Yeah, exactly. We definitely expect pain to have this loud, sudden origin story, like a specific moment in time you can point to and say, there, that's what happened.
Right. But sometimes pain isn't about what happened to your tissue in a split second. Sometimes it's actually about what the tissue is slowly, quietly missing over years.
Mm-hmm.
It's less like a sudden bone fracture and more like, I don't know, a suspension bridge slowly rusting over decades.
Yeah.
Eventually its cables just can't hold the weight anymore.
That is a really great way to look at it.
And that quiet rusting is exactly what brings us to today's deep dive. We are taking this massive stack of clinical guidelines, including detailed NHS documentation, medical device reviews, and some highly rigorous randomized controlled trials to figure out something very specific.
Right, our core mission today.
Exactly. We want to know if that rust, which in this case is vaginal dryness, is the actual direct cause of dyspareunia. And just to get the medical jargon out of the way immediately for you, dyspareunia simply means pain during sexual intercourse.
It is a phenomenal question to ask, really, primarily because, well, up to 50% of postmenopausal women experience this condition.
Wow, 50%, that is huge.
It is, yet the data shows it remains chronically undertreated. When you dive into the sociological surveys included in our sources, you find that out of the women who don't seek help, a huge portion remains silent simply because of embarrassment.
Oh, that's terrible.
Or because society has basically conditioned them to assume this pain is just an inevitable, unavoidable part of aging, which it isn't.
Which is just heartbreaking to read, considering how fundamentally it impacts a person's quality of life. I mean, their intimacy, their overall psychological well-being.
Absolutely. And to truly understand if the dryness is the mechanical driver of that pain, we have to look beneath the surface. We have to examine the hidden architecture of the body when hormone levels begin to shift.
Okay, let's unpack this.
Yeah.
Because our sources show that the link between dryness and pain isn't just about a lack of surface moisture.
No, not at all.
The medical literature actually points to a literal structural collapse at the cellular level.
Yeah, so in the clinical community, this overreaching condition is diagnosed as Genitourinary Syndrome of Menopause, or GSM for short. Older texts might refer to it as urogenital atrophy.
Okay, GSM. Got it.
Right. And to visualize the collapse, you first have to grasp the mechanics of the healthy baseline. So in a healthy premenopausal vaginal ecosystem, the superficial epithelial cells, those are the cells lining the topmost surface they're constantly shedding. They turn over every few hours.
Like skin exfoliating itself on a continuous loop, basically.
Exactly like that. And as those specific cells shed, they burst and release large amounts of a carbohydrate called glycogen. That glycogen is essentially the foundational food source for lactobacilli, which are the dominant healthy bacteria that maintain the entire vaginal microbiome.
Oh, interesting. So they feed the good bacteria.
Yes, the lactobacilli consume the glycogen and then they produce lactic acid. This localized ecosystem keeps the whole environment highly acidic, highly resilient, and incredibly elastic.
So the glycogen is basically an all-you-can-eat buffet for the good bacteria. Which in turn keep the whole neighborhood safe and functioning.
That is a perfect way to describe it. But that ecosystem is entirely dependent on circulating estrogen.
Right, of course.
So when estrogen levels plummet, whether that is a result of natural menopause, systemic chemotherapy, certain breast cancer treatments, or even surgical removal of the ovaries, a severe domino effect begins.
And this is where the collapse starts.
Exactly. The mucosa, the lining, becomes paper thin. The proportion of those superficial glycogen-producing epithelial cells drops to less than 10%.
Less than 10%. Wow. So with fewer cells shedding, the glycogen buffet abruptly shuts down.
Right, the doors are closed.
And the lactobacilli literally starve to death. And, nature abhors a vacuum. Our sources detail how, without the good bacteria maintaining that protective lactic acid, opportunistic organisms like E. coli just rush in to take over the real estate.
Yes, and as a result, the vaginal pH spikes above 5, becoming far less acidic. This shift is actually the exact mechanism that explains why women with GSM suddenly start battling recurrent urinary tract infections.
That makes so much sense. But that pH shift and the thinning lining, that just represents the surface level damage, right?
Correct. The true mechanical source of the pain, the dyspareunia itself, originates deeper down, below the epithelium, down in the connective tissue.
Okay, what happens down there?
Well, the predominant cells running the factory down there are fibroblasts. Their primary job is to manufacture fresh collagen and elastin.
Which gives the tissue its stretch.
Exactly. But postmenopause, in the absence of estrogen to stimulate them, these fibroblasts essentially power down. They just go to sleep, transforming into dormant fibrocytes.
And the clinical data detailing what happens next is just truly shocking. I mean, without fresh collagen being pumped out, the existing collagen fibers in the dermal layer physically alter. Our sources say they hyalinize.
Yes, hyalinize.
Which means they literally fuse together into a stiff, rigid mass. Concurrently, the elastin fibers, the actual things that give tissue its stretch, they fragment and break apart.
Right, so the tissue loses its mechanical integrity entirely.
Reading through the pathology reports in the stack made me think of an analogy for you. So imagine a rubber band that you've left out on your car's dashboard, baking in the hot sun for a year.
Oh, that's vivid. I can picture that.
Right. It dries out, it completely loses its bounce, and as you try to stretch it, it doesn't just resist the tension. It causes microscopic tears or it snaps entirely.
That is exactly what happens on a cellular level.
And that beautifully and, well, painfully explains why the dryness mechanically leads to the friction, trauma, and tearing of dyspareunia. It's not just a patch of unlubricated skin, it is physically degraded, fundamentally altered tissue.
That rubber band analogy perfectly illustrates the structural reality. It is a profound loss of tissue architecture.
So once you understand that your collagen is fusing together and the tissue is literally tearing, I think the immediate listener instinct is to just lubricate it.
Yeah.
You see a dry sponge, your brain says to add water.
Very natural instinct, sure.
But our sources draw a massive line in the sand between temporary relief and actual cellular repair. So let's look at the first line of defense the medical guidelines recommend, which are moisturizers and lubricants.
Right. And there is a vital clinical distinction between the two, which is heavily emphasized in the NHS prescribing guidelines.
Let's hear it.
Well, lubricants brands you might recognize, like ESWB or Silk, they are purely short-term situational solutions. They are typically water or silicone-based, and they're applied immediately prior to sexual activity solely to mitigate surface friction at that specific moment.
So they basically act as a temporary slip layer to stop that sun-baked rubber band from catching.
Exactly. Moisturizers, conversely like Replens or YesVM, are considered therapeutic maintenance. They are meant to be used every few days, entirely independent of sexual activity.
So you use them just as part of a regular routine?
Right. Their molecular goal is to actually alter the fluid content of the epithelium, mimicking normal vaginal secretions and gradually coaxing the pH back down over time.
I have to push back on the clinical guidelines here, though.
Okay, go ahead.
If the severe tearing pain is being caused by dormant fibroblasts and a fused collagen matrix beneath the surface, aren't these over-the-counter moisturizers essentially putting a Band-Aid on a bullet wound? I mean, adding fluid to the surface doesn't magically reach down and reverse the tissue damage, does it?
You're touching on a very critical limitation. You're right. They are highly effective at relieving the daily symptom of dryness.
Right.
In fact, clinical trials actually demonstrate that a high-quality, rigorously applied moisturizer can match the efficacy of local estrogen when it comes to alleviating the day-to-day feeling of being dry.
Oh, wow. That's impressive for just an over-the-counter product.
It is. But they absolutely do not reverse the underlying cellular atrophy. They cannot wake up those dormant fibroblasts or unfuse the collagen. What the fascinating here is the rigorous science of how these temporary products have to be formulated just to ensure they don't make that underlying damage worse.
So the chemistry of the products themselves matters a lot.
Immensely. The NHS guidelines stress that the pH and the osmolality of any applied lubricant or moisturizer must meticulously match the body's natural secretions.
And osmolality is essentially the concentration of particles in a fluid, right?
Exactly. If you use a generic product with high osmolality, it acts like a microscopic sponge. It will literally suck the water out of the already fragile vaginal cells, causing them to shrivel up and die. It accelerates the tissue damage.
Which is exactly why the clinical sources explicitly warn against using household workarounds like petroleum jelly with condoms, and they urge extreme caution with highly perfumed soaps or generic body lotions.
Yes, please don't use those.
Because you can trigger massive inflammation in an already compromised ecosystem.
Absolutely. So while moisturizers are a vital tool for immediate comfort and symptom management, they simply do not rebuild the rusting bridge.
Right.
To actually reverse the structural tissue changes that trigger the pain, the clinical pathway escalates to the big guns.
The hormonal heavyweights.
Right.
Because, like you said, over-the-counter interventions can't unfuse the collagen. So the medical consensus pivots to treatments clinically proven to reverse that specific atrophy.
Yes.
We're talking about topical estrogen, and we really need to clarify what that means because the word estrogen carries a lot of baggage for people.
It really does. When the guidelines specify topical, they mean strictly localized therapy. This is fundamentally different from systemic hormone replacement therapy, or HRT, which is circulated through your entire bloodstream.
Right.
Localized estrogen is an incredibly tiny microdose applied directly to the vaginal tissue.
It bypasses the liver processing entirely. It just binds directly to the estrogen receptors waiting right there in the vaginal wall.
Exactly. The systemic absorption into the rest of the body is so minimal it barely registers on blood tests.
And the modern options available to deliver this are really remarkable. The sources highlight a couple of standout treatments. First, there's Gina.
Right, Gina?
This is a 10 microgram estradiol vaginal tablet. And a massive shift in healthcare policy here is that it's now available without a prescription in many pharmacies for women over 50.
That was a huge step forward for accessibility.
It really was. It delivers a microscopic dose of estrogen directly to the vaginal wall, signaling those dormant fibroblasts to wake up and get back to work.
And for patients who prefer not to manage daily or weekly tablets, the guidelines point to sustained release options like estring.
Which is a very different approach.
It is. This is a flexible synthetic ring inserted into the upper vagina that simply stays in place for 12 continuous weeks. It steadily releases just 7.5 micrograms of estradiol every 24 hours.
Very low dose.
Very low. It functions as a set-it-and-forget-it mechanism that consistently rebuilds the mucosal thickness over a period of months.
We also have to acknowledge that some people cannot, or choose not to, use standard estradiol. The sources present a brilliantly engineered alternative for this exact demographic, which is Interosa.
Interosa is fascinating. It's a daily pessary, but its active ingredient isn't estrogen. It actually contains 6.5 milligrams of prasterone.
And what exactly is a FACE?
Prasterone is simply a synthetic version of DHEA, which is a precursor hormone that the human body naturally produces in the adrenal glands.
And the biological trick of DHEA is what makes it so revolutionary for dyspareunia, isn't it?
Yes, exactly.
When you insert it, the vaginal mucosa absorbs the DHEA, but it doesn't stay DHEA. The local cells contain specific enzymes that convert that precursor molecule into both estrogen and testosterone, right there inside the local tissue.
Yes, in endocrinology, this is known as interchronology. It's hormone creation happening inside the specific cell that needs it, without spilling into the general blood supply.
That is incredibly efficient.
That dual conversion is the secret weapon. The localized estrogen handles the heavy lifting of rebuilding the epithelial layers, restoring the glycogen buffet, and lowering the pH.
And the testosterone.
Meanwhile, the localized testosterone is increasingly recognized in the literature for improving the quality of the connective tissue, enhancing local nerve function, and even positively impacting local arousal and orgasm.
So what does this all mean? It means these targeted hormonal treatments are actively rebuilding that sun-baked rubber band back to its original supple elasticity.
That's exactly what they do.
They are chemically instructing the body to manufacture fresh collagen, shed healthy new cells, and restore the exact structural integrity the tissue possessed prior to menopause. They don't just mask the friction. They actually cure the mechanical root cause of the dyspareunia.
However, we must confront a major clinical caveat found throughout the literature.
Right.
What if you are a breast cancer survivor, particularly someone who has battled an estrogen receptor-positive cancer?
That completely changes the landscape.
It does. Many oncologists will strictly advise against any localized estrogen or DHEA out of an abundance of caution regarding any potential systemic absorption, no matter how microscopic.
That is a profoundly frustrating position to be in. To be told there is a biological cure for your severe pain, but you are medically banned from touching it.
That's incredibly difficult.
And that desperation leads us to the most controversial and undeniably the most heavily marketed treatment in our entire stack of research, which is vaginal laser therapy.
You'll see these heavily advertised under names like fractional CO2 lasers, the Mona Lisa Touch is a famous one, or erbium lasers.
Right.
The proposed mechanism sounds incredibly intense, but it actually borrows heavily from established dermatological anti-aging procedures used on the face.
So the laser probe is inserted transvaginally. It fires energy into the tissue, creating thousands of microscopic dermal lesions, essentially tiny controlled burns in the vaginal wall.
Yes. The laser energy is actively hunting for residual water molecules inside the vaginal tissue. By vaporizing that water and creating these microlesions, the procedure triggers a massive trauma response in the body.
And this has a specific name, right?
Yes, this mechanism is called neocollagenesis. The theory is that by causing controlled damage, you trick the body's emergency repair mechanisms into rushing blood to the area. This forcefully wakes up those dormant fibroblasts and demands they manufacture new collagen to heal the thermal burns.
I mean, it sounds like a sci-fi miracle cure for women who can't take hormones. But then you look at the financial realities, and more importantly, the clinical evidence.
Yes, we need to look closely at both.
Let's talk sticker shock first. These treatments are almost never covered by insurance or national health services. You are looking at paying between £600 to £1,200 per session.
Per session, that's a huge burden.
And the protocol typically demands 3 sessions spaced roughly 6 weeks apart, plus mandatory annual maintenance sessions.
When out-of-pocket costs run that high, rigorously analyzing the clinical data becomes a moral imperative. And when we cross-reference the studies in our stack, we find a massive, glaring contradiction in the evidence.
It really is a tale of 2 very different types of science.
The initial wave of observational studies where clinics simply performed the laser treatment on paying women and asked them to report how they felt weeks later showed phenomenal results.
Like, how phenomenal.
We are talking about reported 60% improvements in dyspareunia and massive statistical drops in vaginal dryness scores.
That sounds incredible. But the scientific method demands a control group. And when the medical community finally conducted high-quality, double-blind, randomized controlled trials, specifically trials like the landmark Velvet study, the narratives basically collapsed.
It did.
In these rigorous studies, they compared the actual laser treatment to a sham procedure.
Right. And a sham procedure is basically the surgical equivalent of a sugar pill placebo. The researchers insert the exact same laser probe, the machine makes the exact same firing noises, and the session takes the exact same amount of time.
But the laser isn't actually doing anything.
Exactly. The laser energy is either completely turned off or set so infinitesimally low that it cannot penetrate or alter the tissue, and the patients do not know which version they are receiving.
And the results of the Velvet trial were damning. Both the group receiving the actual laser burns and the group receiving the sham procedure reported significant improvement in their symptoms.
Yes. The researchers found no statistically significant difference in symptom resolution between the women who received the expensive tissue-altering laser and the women who received the placebo.
So why did both groups feel better?
The improvement in the laser group was largely attributed to the placebo effect and the extensive vaginal lubrication used during the insertion of the probe. Because of this high-level data, the official NICE guidance firmly states that the evidence on long-term safety and efficacy is inadequate.
Okay, so what do they recommend?
They recommend this procedure should only be used in a highly monitored research context, not sold commercially.
If failing to beat a placebo wasn't enough to give patients pause, we have to talk about the dark side of the laser.
Yeah.
The case studies included in the stack highlight some incredibly severe, life-altering complications from the thermal damage.
It is a tragic irony. A highly expensive treatment actively sought out to cure the pain of dyspareunia resulted, in several documented cases, in the catastrophic worsening of that very pain.
We read clinical case reports of women who underwent laser therapy and subsequently developed severe vaginal canal strictures. The thermal burns healed poorly.
Yes, that scarring is a massive risk.
In one specific case, a crescent-shaped fibrous band of dense scar tissue formed, physically blocking the vaginal canal entirely.
Awful.
In another harrowing report, a woman who had undergone the laser treatment resumed intercourse weeks later and suffered excruciating vaginal wall lacerations where the tissue had become dangerously friable.
It breaks your heart to read.
She was left with a foreshortened vaginal canal that required intense, painful physical therapy and the use of dilators just to regain basic function.
This raises an important question. Is it ethically justifiable for clinics to heavily market a procedure with such exorbitant out-of-pocket costs and non-trivial risks of severe scarring, when the highest quality randomized trials suggest its benefits might not exceed a placebo?
It's a question anyone considering the laser needs to discuss deeply with their primary care doctor or gynecologist, especially when weighed against the proven, low-cost efficacy of localized hormones, or even a highly rigorous, osmolality-matched moisturizer routine.
The clinical data strongly points towards starting with the least invasive, most physiologically proven methods first, Rebuild the ecosystem with the tools the body actually recognizes.
So let's bring all of this complex biology together for you. We set out at the beginning of this deep dive to answer a very specific question. Does vaginal dryness directly lead to dyspareunia? The answer is a definitive mechanical yes. But it's not simply a surface friction problem. It is a profound structural breakdown. The lack of localized estrogen leads to a cascade of cellular starvation, collagen fusing, tissue thinning, and a complete loss of the elasticity required for pain-free intercourse.
But the overwhelming takeaway from the medical guidelines is that science offers a clear, highly effective ladder of interventions. From daily, scientifically formulated moisturizers that restore fluid balance, to localized estrogen and DHEA that actively reverse the cellular aging process at the receptor level.
So there is hope.
Absolutely. You have the tools to rebuild that tissue architecture.
Here's where it gets really interesting.
Yes. So throughout this entire deep dive, we have focused entirely on the physical tissue changes. We've talked about epithelial cells, glycogen, fused collagen, and elasticity.
Right, the mechanical stuff.
But we have to remember that human pain is also deeply neurological. If a person experiences severe tearing pain from dryness during intercourse over a period of months or years, their brain learns to anticipate that specific pain.
It remembers the trauma.
Exactly. In response, their pelvic floor muscles might start to reflexively spasm and guard the area to protect the body before intercourse even begins. This is a secondary condition called high-tone pelvic floor dysfunction.
Wow, okay.
Which means, theoretically, you could use an estrogen ring or a DHEA pessary, perfectly cure the physical dryness, restore the collagen, have completely healthy elastic tissue.
Oh, I see where this is going.
And still experience dyspareunia. Because the brain is still pulling the fire alarm, the muscles are still bracing for an impact that the nervous system remembers.
That is wild.
It leaves you wondering, will the next major evolution in treating dyspareunia require us to treat the brain's memory of the pain just as aggressively as we treat the tissue itself?